Thank you very much for the opportunity to present today. And I'm going to present on cardiovascular systems and psychiatric comorbidities and complete my talk by discussing aortic dissection. My name is Jeff Daskalakis. I am professor of psychiatry and chairman of the Department of Psychiatry at the University of California, San Diego. I begin my presentation by talking about the challenges of the consult liaison setting. And I want to take a step back before we get into the granular details of psychiatric aspects of these conditions and talk about consult liaison psychiatry more broadly. And consult liaison psychiatry deals with psychiatry that intersects with the general hospital. And our patients oftentimes come in and have an enormous number of worries, stresses, anxieties, frustration that are associated with having severe medical illness. And oftentimes the consult liaison psychiatrist has a great deal of challenge disentangling what is psychiatric from what is a reaction to the medical condition, for what is psychiatric in relation to the medical condition, to what are our challenges in relation to some of the medications that are treated, both medical medications that are used for medical conditions, but also psychiatric medications that treat psychiatric conditions and that interact with medical conditions. And then finally, an awareness of all the side effects, both medical and non-medical. So as I mentioned, there's considerable overlap between psychiatric and medical care, and these patients who have severe medical illness struggle a great deal. And those can be defined broadly into medical domains and psychiatric domains. The psychiatric presentation of medical conditions, again, medical presentations of psychiatric conditions, psychiatric complications of medical conditions and their treatments, medical complications of psychiatric conditions and their treatments, psychological reactions to medical conditions, which is front and center here, and also comorbid medical and psychiatric conditions. So talking about cardiology, again, more germane to this audience and the psychiatric sequelae of cardiovascular changes. So heart disease is specifically associated with anxiety, depression. We know that depression is the most common psychiatric disorder in patients with coronary artery disease. Up to 15 to 20% of patients experience depression. After coronary artery bypass surgery, up to 30% of patients may experience depression. In patients with congestive heart failure, we see depression commonly. And depression in and of itself is an independent risk factor for the development of coronary artery disease and increases the risk by 1.5 to 2-fold. Depression quadruples the relative risk of cardiac mortality in those with heart disease. So having depression together with coronary or heart disease can significantly amplify the risk of having an adverse outcome associated with heart disease. And depression is a predictor of mortality after an MI with a 3 to 4-fold increase in risk, meaning that if you look at someone who's had an MI with depression versus someone who's had an MI without depression, there's a significant increase, a 3 to 4-fold increased risk of death in patients who have depression. So something to be very mindful in our patients and something to carefully screen for on the part of medical providers. Unstable angina patients experience depression are 4 times more likely to have an MI or die the following year. Depression is a strong determinant of health status than a stronger determinant of health status than objective measures of heart disease. So paying particular attention to depression in this population is of paramount importance. And depression and coronary artery disease are associated with nicotine addiction, leads to challenging compliance in these patients. It affects their cardiac conduction, heart rate variability, and just having anxiety and distress causes significant stress on the heart itself. Anxiety is associated with coronary events and arrhythmias. Patients with severe anxiety can experience arrhythmias as a result of the anxiety. Anxiety adversely affects the outcomes in coronary artery disease. Anxiety after an MI is associated with more frequent episodes of unstable angina and more recurrent MIs. And post-MI anxiety is the strongest predictor if they're in hospital with complications. In other words, having anxiety post-MI leads to a higher number of complications while in hospital. Anxiety can be medicated, and those medications can cause their own problems, including changes in heart rate variability, changes in the heart rhythm, and associated abnormalities. And some of the medications used can also be associated with high rates of anxiety. And personalities, including the fabled type A personality, which includes impatience, hostility, intense achievement drive, those are psychiatric aspects. Type A personality is not necessarily a psychiatric disorder, but the intensity that is associated with the type A personality can be a risk factor for developing coronary artery disease. some hostility in some of our patients can be associated with significant stress in the body and increased coronary events and mortality. Confusion after surgery can also complicate things. And coronary artery bypass patients in general who experience a large cardiovascular surgery may experience cognitive function as a result of the surgery, and may still have impairments as of out to 6 months. And there's a high level of anxiety, which is the strongest predictor for development of hypertension. In other words, having high anxiety in and of itself can lead to the development of hypertension. It is important to note that when patients with psychiatric disorders experience medical comorbidities, it's not always the same as treating a patient with a psychiatric disorder who does not have a medical comorbidity. So together with one of my trainees, Helena Kim, who's an outstanding junior investigator back at the University of Toronto, we undertook to evaluate what were the antidepressant outcomes in patients who had depression, but who had other psychiatric comorbidities and who had other physical comorbidities. And we looked at 20 studies of patients who had psychiatric comorbidities and 6 studies of patients who had physical comorbidities that included a large number of patients. The psychiatric comorbidities included anxiety disorders, personality disorders, etc. And our physical comorbidities included cardiac disease, diabetes, arthritis, etc. What we found was that in those patients who had physical comorbidities, clinical outcomes were far less favorable using antidepressants than in patients who did not have physical comorbidities, suggesting that our medications in and of themselves do not work as effectively in patients with physical comorbidities than in those without physical comorbidities experiencing psychiatric and experiencing antidepressant treatment. And we found a similar pattern, incidentally, in patients with psychiatric comorbidities. That is, if you had an underlying anxiety disorder and developed a depression, you were less likely to respond to the antidepressant compared to if you did not have a comorbid psychiatric disorder. So there's not a lot of attention or not a lot of research that has been done so far in understanding the psychiatric sequela of patients with Marfan's syndrome. But there were some studies, and one in particular that I wanted to highlight that was recently published in BMC Psychiatry, and it looked at the effects of acute and elective cardiac surgery on anxiety traits of patients with Marfan's syndrome. This is a paper, the authors are listed there. Marfan's patients, in a total of 45, had filled the questionnaires, 26 women, 19 men, and you can see the demographic groups. 3 sample groups were established based on surgical procedure. Group 1 had acute aortic surgery, Group 2 had prophylactic surgery, and Group 3 had no surgery. The authors suggested that surgery for aortic symptoms can be experienced as a traumatic event that is constant, life-threatening, and hard to define distress. But importantly, they did not find a significant difference in depression. That is, patients with Marfan's who were undergoing aortic surgery did not differentiate from patients who had Marfan's who were not undergoing surgery in terms of depressive symptoms, only in the context of anxiety. And significant factor contributing, and the surgery itself was a significant factor contributing to permanent anxiety. And this was also reported by Fusar-Poli in 2008, which found that Marfan's patients had negative influences on quality of life, increases in psychological distress, and the Marfan's itself may be a possible risk factor for some psychiatric disorders. So I began by giving you a long introduction around the psychiatric sequela of medical conditions and the medical sequela of psychiatric conditions, and concluded by highlighting Marfan's syndrome. And what we found, and most importantly, is that Marfan's is associated with considerable comorbid anxiety. Psychotherapy may be needed in the majority of these patients, and medication should be considered when symptoms are severe, moderate to severe. Medications may have limited efficacy because this population, patients with comorbid medical conditions, particularly depression, may be difficult to treat and may not respond as favorably to people who have depression who do not have comorbid medical conditions. And advanced treatment intervention may reduce the psychological sequelae. Advanced treatment meaning advances in treatment, but also advanced treatment in terms of making sure that we identify these patients early and get them the psychological support that they need. Consult liaison psychiatry, particularly in a hospital setting when these folks are coming in, may have a significant role in reducing distress and burden over the hospital period, and may also be helpful in reducing the confusion that takes place in anticipation or after surgery. And proactive interventions, including CBT, which is cognitive behavioral therapy, which helps patients understand the complexities of the illness and helps them manage the anxiety that may be associated with surgery effectively, may be key. Thank you all again for your attention, and I look forward to speaking to you in some of the follow-up groups.